Good morning. My name is Julia Challenor. I'm a pediatric oncology nurse, and I'm the former Secretary General of the International Society of Pediatric Oncology. I welcome you this morning. We're just waiting for a couple more people to join, and then we'll go ahead and give you Zoom instructions, and we'll begin. It looks like we have a stable number on the participants, so I'm going to go ahead and start. To give the housekeeping slides, we welcome everybody who's joined us for the next 2 hours. We hope you can stay for the full 2 hours. These are the Zoom instructions. We're going to have simultaneous interpretation in Spanish and also back in English. So I'm going to give you instructions just in case you're not familiar with this, how to connect. To follow the meeting in Spanish, you're going to click on the globe icon below. You'll see this light blue arrow here, and you'll click on this globe that says interpretation if you have English on your screen. And then you can select your language. It says here Russian, but you will see Spanish. Click on Spanish. Or you might see it like this in your mobile phone. If you're connecting by phone, you'll see 3 little dots. Again, look at the light blue arrow. It will say language interpretation, and then you'll pick your language. In this case, you'll pick Spanish. We're going to have a chat and a Q&A. We'd like you, if you have a comment or a question, please put it in the Q&A. Preguntas y respuestas if you're in Spanish on your side. You can put your question in Spanish, and we will translate it to English so that the speakers can answer you. You can also use the chat to make a comment if you prefer, but we will not be monitoring that. The mobile view, this is what the chat will look like. You'll have a little chat symbol. I think most people nowadays are used to knowing how to manage this. But to use the Q&A, which is the most important because that's where we're going to look for your comments and questions, you click on the Q&A in English here below, and it will give you this window, and you will be able to type here your comment or your question. In the mobile view, it will look like this. Welcome to Q&A. If you click here at the bottom, and then you can type, and then you can, we will see your question or your comment. So let me stop sharing. And it's my pleasure to introduce the president of the International Society of Pediatric Oncology, Dr. Guillermo Chantada, for a few words to welcome you.
Oh, thank you very much, Julia. The honor is entirely mine. I am Guillermo Chantada. I'm pediatric oncologist. I'm SIOP president. I just wanted to tell you with an anecdote how proud I am to be here with you today. Well, when I was a boy, I was a small child. In fact, I read a lot. I like to read comic books, and I remember reading a comic book, which was very impressive to me. I still remember that moment, and that was a comic about an alchemist, someone that could touch things and become gold. And I thought I was like 5 years old or 6. I was so wow, that is great. That is even better than become a magician, because magicians usually tend to disappear things. But these guys really touch things and become gold. So that is how I feel today. I feel today that I'm sitting in the table with the alchemists. You guys are able to become gold, the most difficult things that could happen in the world, the suffering, the losing of a very, very dear person, or becoming a survivor after having cancer, childhood cancer. So today, I'm so proud to sit in the table of the alchemist, as I saw when I was 5 years old. So thank you very much for having me today, and let's enjoy and celebrate this very important day.
Thank you so much, Dr. Shantana. It's a pleasure to be here. Now, let me give the orientation to the audience. You've seen the flyer, so you will be familiar that the first hour is going to be 4 professionals who work with children with cancer, and they're going to each present their view of our theme today, which is communication in childhood cancer and stigma. Then we're going to follow that with an hour of people who have survived childhood cancer. We're going to share their perspectives and speak on the same theme, and we will introduce each of them in turn when we get to that hour. We are keeping the presentation short because we would like to have the audience have a chance to ask questions, make comments, share their experiences. We're not going to open the microphone for the audience, but we're expecting and hoping you will write in the Q&A, and we will transmit your questions or comments to the speakers, and they will be able to respond. The second half is a roundtable. The first half will also be like a roundtable once the panelists have finished their presentations. We thank you for joining, and with no further ado, I'm going to introduce this first speaker. Dr. Yamini Krishnan is the head of the Pediatric Hematology and Oncology and BMT unit at the MVR Cancer Center and Research Institute in Calicut, Kerala, India. She is the chair of the Neuroblastoma Subcommittee of INPOG and research organization of the Pediatric Hematology Oncology chapter of the Indian Academy of Pediatrics. She is the co-chair of the Protocols and Clinical Trials Subcommittee of the Indian Childhood Cancer Initiative, working for the improvement of the care of children with cancer in India, involved in the advisory committee of various non-governmental organizations. Through her clinical interests, she ties in the field of pediatric oncology. She is very much interested in studying the social aspects in the lives of children affected with cancer and mitigating the barriers associated with the reintegration process of our children into the society. Welcome, Dr. Yamini. Over to you.
Yeah, thank you, Julia. Yeah. Hope the screen is clear. Yeah, thank you. So it's great to be part of the CCI Survivors webinar. And thank you very much for this opportunity. So I have been asked to talk on one of our publications related to the topic of stigma. Public perception on childhood cancers from a population-based study in South India. Lessons to learn to avoid stigma. So let me just give you an overview of our setting. I come from the south of India, right at the bottom of the Indian subcontinent, a small state called Kerala. Kerala is known for its high literacy rate, a high female literacy rate, and good, human health indices like a very good infant mortality and maternal mortality rates. So our health indices are quite good. Let me just tell you an important point that this setting might not be the same setting in the other parts of India. So it will be different from what you see in other parts. And I work in MVR Cancer Center, which is situated in a rural setting. So this is our publication, and we got it published last December in the Paediatric Hemato-Oncology Journal. The background of our study was that social workers had informed us about a lot of concerns in the society, lots of myths, misconceptions regarding pediatric cancer, and many of the children were discontinuing treatment because of these myths. And the second concern was the parental concern on the stigma of cancer. Basically, a child with cancer was always labeled as a cancer patient. even after they would become a survivor, even after 5-10 years, they would still be called a cancer patient rather than a normal child. So right to forget cancer was always the, the intention of the parent, but that would never happen in the society. So to know the actual situation in the society, our community oncology department, along with our department and the clinical research team, went to community camps, which was actually weekly conducted in our with our hospital, in schools, churches. This was a direct interview method. So basically, we asked the community on what do you know about pediatric cancer. So I'll just directly go into the questions. Initially, they were general questions, and most of them knew about the results were actually quite impressive. What was there 20 years back and what is now. A lot of the questions were very well answered in our community. And most of these data of the respondents were from TV, cinema, print media. Some of them had these opinions from social media. And some people actually knew about pediatric cancer personally knowing a child. So let's go into the general questions. If you see, awareness of pediatric cancer was there in the community. A good amount of people did knew about pediatric cancer, and the gender predisposition, as any girl, boy, child, all of them were predisposed to cancer. Any age could be affected by cancer. All these were very well understood by the community. But as you can see, regarding the perceived causes of childhood cancer, what was very striking is that 1/3 of the patients, of the respondents, actually thought that it was a God's curse. Food habits, mistakes of the parents, environmental factors, bad behaviors of the children, all these were implicated as the causes of pediatric cancer. So that was very interesting results that we got. Some of the general other questions we asked were, is pediatric cancer curable? That also was well answered by 3/4 of the people actually did know that pediatric cancers were curable. The percentage curability also was quite well answered by them. They knew that the pediatric cancer was not infectious. So very well answered all these questions. An interesting point was that that is half of the respondents felt that pediatric cancer is curable, but also through prayers and alternate treatment. So that too was quite interesting. Coming to the social aspects, I would like to re-emphasize 2 points that were in the questionnaire. One was, would you disclose the diagnosis of childhood cancer to the family or the society? So a good number felt that we shouldn't disclose, and they felt that this would affect the future of the child, will affect the siblings, would affect the family in general. Some had other answers also. So majority was affecting the future of the child, would affect the siblings, would affect the family. The other thing what we asked was, why do people hesitate to take treatment despite knowing it's curable? So that also fear about adverse effects, wrong beliefs, fear about treatment expenses, wrong misconceptions and wrong information. All these were re-emphasized in the the respondents responses we had. The other question we asked was, can a child actually return to normal life after completion of treatment? Only around 44% actually felt that a child who has completed treatment would return as a normal child into the society. And the understanding for the reasons were very interesting. Some felt that it is probably due to the adverse effects of drugs, social isolation, complications of the disease. So a lot of varied answers we got. But what was striking was 44% actually felt that a child having survived a cancer would never return to normal life. So we did another study actually regarding the resilience among caregivers of pediatric cancer patients. This is actually to re-emphasize the social aspects of the reintegration process of children. So we did a quantitative analysis as well as qualitative analysis. If you see the quotes that are given on the right side, some mothers actually felt that I do not interact with anyone in the society except the doctors and nurses. Actually, I don't even attend to phones because they inquire of the illness but offer only sympathy. And the other thing was that they critically actually blame me for the child becoming sick. So, and they say that probably it's because I didn't take care of the child properly. So definitely these aspects actually cause social isolation of those families with a child affected with cancer. And definitely this would affect the reintegration process of our children. So after our results, what did we do and what we can do? So what we did was, one, we have started proactively taking classes in the community, among social workers, among health workers, among Anganwadi workers. These are the rural workers who actually do the health checkup among the community. So we have actively started educational processes within our community. The second thing that we have done is we have formed social support groups. One of our support group is what's called Changadi Kootam, or friendship in our language, for the adolescent survivors. And the second group that we have is retinoblastoma support group. That is, these are for retinoblastoma mothers whose children have been affected with retinoblastoma. What we can do as a community, one, probably we can increase the educational aspect in the community, try to do more educational work in the community, re-emphasizing the fact that these children who have survived the disease are perfectly normal and as normal as any child in the community. And second thing is probably we can increase the advocacy groups, including more survivors, so that it is so evident that these all our children are as normal as any child in the community. Yeah, thank you for patiently hearing. Thank you very much. And once again, let me thank CCI and SIOP for giving this opportunity. Thank you very much.
Thank you so much, Dr. Yamini. It's been a pleasure hearing your presentation. Is it possible to close your slideshow? I'm going to move on now and introduce Mara Ayala, who is a PhD, and she's going to speak in Spanish. So you will, when she begins, you will want to check your globe if you don't understand Spanish, and you can switch to the language you prefer there. Dr. Ayala is the founder and director of Imagina Paediatric Psycho-Oncology, a nonprofit in Aguas Calientes, Mexico, tending to the psychosocial needs of patients and their families. She also created the integrative extra and intra hospital psycho-oncological intervention model, now integral to the institution's operations. Welcome, Mara.
Gracias, Julia. Gracias, CCI y SIOP, por esta oportunidad de compartir un poquito de las reflexiones que hemos hecho a lo largo de 10 años. Voy a hacer chiquito aquí. Bueno, espero que estén viendo ya mi pantalla.
Sí, está bien, gracias.
Ajá, déjenme mostrarles un poquito dónde está Aguascalientes. Está en el corazón de México. Es un estado pequeñito. Y bueno, un poquito de las estadísticas a nivel nacional, tenemos alrededor de 5,000 casos nuevos cada año, donde el principal cáncer, el tipo de cáncer es la leucemia. Y en nuestros hospitales, los dos principales públicos es tenemos alrededor, de 150 niños activos en tratamiento activo. Como les digo, es un estado muy pequeño, pero eso nos ha permitido en Imagina acceder a la descripción de los significados que tiene el paciente y la familia respecto a la enfermedad. Nuestro enfoque está centrado precisamente en el paciente y su familia, y consideramos a la persona como un ser biopsicosocial y espiritual, entendiendo por espiritual esta parte del sentido de vida. Y sí, los niños, aunque sean pequeños, como cualquier persona, tiene esta dimensión y la expresa. ¿Sí? Nos interesa conocer la comprensión que hace la persona y la descripción que nos da acerca de cómo está viviendo y experienciando este tránsito por la enfermedad, porque a partir de ahí, a partir de lo que para la persona significa, nosotros pues trabajamos con ella. A lo largo de estos 10 años hemos escuchado muchas veces esto de la metáfora bélica, que es de lo que yo les quiero platicar, de algunas reflexiones que hemos hecho a lo largo de este tiempo. ¿Por qué nos referimos, por qué usamos esta metáfora cuando hablamos del cáncer? La batalla, la guerra, la lucha. Como bien decía la doctora Yamini, cómo algunas familias piensan que esto es un castigo, que es una prueba. Y bueno, hace años que me pregunto esto y claro que una de las respuestas que empecé a encontrar fue a través de Susan Sontag en su libro La enfermedad y las metáforas, donde dice que las metáforas patológicas siempre han servido para reforzar los cargos que se le hacen a la sociedad por su corrupción e injusticia. Y ella escribió este libro justo cuando ella estaba transitando por un cáncer que finalmente la llevó a su fallecimiento. Y ella dice que las metáforas patológicas se prestan mucho si son misteriosas, si no se sabe las causas. Y esto es lo que pasa con el cáncer, ¿no? Que se prestó muy bien para convertirse en esta metáfora social. También tuvo que ver, creo, esta iniciativa de Nixon en el 71, que fue la National Cancer Act, que de hecho, básicamente Nixon le declara la guerra al cáncer, y cosa que no fue mala, pues inyectó recursos para investigación, para que se tratara este asunto, pensando en que podía ganar esa guerra. Ya vimos que no, es un proceso mucho más complicado, largo y difícil, pero creo yo que a partir de ahí se empezó a usar esta retórica para referirnos al cáncer. Igualmente, pues los estudios, la medicina nuclear, todo el lenguaje que se utiliza alrededor de la enfermedad. Y Elena Seminó nos dice que el lenguaje bélico puede ser dañino para los pacientes, sobre todo cuando la enfermedad es incurable, ya que termina el paciente sintiéndose responsable por perder ese combate. Y otros psicólogos nos hablan acerca de que la metáfora bélica promueve el poder y la agresión, que son actitudes contrarias o percepciones contrarias a la de prevención, que implica limitaciones, restricciones y autocontrol. Visibilizar que la metáfora bélica produce una ideologización particular de la enfermedad, ya que le atribuye significados, asigna roles e introduce valoraciones morales respecto a conductas deseables o no deseables, tanto a la patología misma como a las personas, a los actores involucrados en ellas. Y todas estas personas que he citado hablan y se refieren en sus estudios a personas adultas. Imaginen poner todo esto en un niño, niña o adolescente. Imagínense la carga también para los padres. De por sí ya algunos llegan en el inicio expresando algún tipo de culpa por algo que hicieron o no hicieron, dejaron de hacer y que eso causó la enfermedad. Es poner esta carga en la persona, lo que vuelve a la metáfora bélica, pues no recomendable para usarse. Y claro, el lenguaje bélico en el campo de la investigación, de la industria farmacéutica y las iniciativas públicas, las ONGs, pues puede ser, tener un impacto positivo porque anima a actuar, a participar, pero el problema es cuando lo ponemos en la persona, cuando le ponemos esta responsabilidad a la persona. Sí, voy a pasar. Estoy un poco, es que no puedo ver toda mi pantalla. Permítanme un segundito. No, ok. Nosotros creemos que el cáncer es un proceso que requiere una actitud en el momento presente, un constante acercamiento hacia sí mismo, ¿sí? Y el niño con cáncer, ante todo, como decía también la doctora, es un niño normal, él lo que quiere es sentirse normal. Y como niño es un ser en desarrollo, es vulnerable y necesita estímulos y cuidados, espacios para que se exprese y a un adulto dispuesto a escucharlo con atención y con respeto. También creo que el niño con cáncer que fallece ha tenido una vida que ha merecido la pena. Ha sido digna, respetable, significativa y aunque corta, ha sido completa. Esta noción anula la visión que dice que la persona que muere a causa del cáncer es porque ha perdido la batalla. Sinceramente, no he conocido a ningún niño, niña o adolescente que yo considere un perdedor. Todos ellos han transitado la enfermedad haciendo su mejor esfuerzo, lo que les corresponde. ¿No sería justo decir que les faltó más ganas o actitud para curarse? Así como absurdo sería decir que los niños de países desarrollados, donde tienen hasta un 90% de sobrevida, son mejores luchadores o le ponen más actitud o más ganas a la curación que en países como el mío, en el que apenas estamos sobre el 57% de sobrevida. Esto evidentemente será responsabilidad de las políticas públicas, del acceso a un diagnóstico y un tratamiento oportuno. Definitivamente creo que no es responsabilidad de nuestros niños. Ahora, ¿qué pasa con los sobrevivientes? Muchas veces ellos nos comparten que escuchan frases como estas: si pudiste con el cáncer, puedes con todo. Dios te da una segunda oportunidad de vida. Haz algo grande. Estás en deuda con la vida. Haz que valga la pena. Y a veces la sociedad le reclama a los sobrevivientes un mayor desempeño. Ya que han sobrevivido al cáncer, entonces se les pide que tengan una vida magnífica o con un desempeño superior al de la población normal. Algunos me han compartido que cuando les dicen, ¿cómo te admiro?, se sienten incómodos, porque evidentemente cuando uno admira a alguien es porque tiene el anhelo de ser como esa persona. Y a ellos no les hace sentido esto, porque quieren sentirse una persona normal, porque lo son. Y bueno, a mí me gusta mucho esta frase de Miriam Algueró que dice: no se trata de ser valientes, ni de luchar, ni de vencer, porque donde hay valientes, hay cobardes, donde hay vencedores, hay vencidos, y donde alguien lucha, alguien pierde. Mi última reflexión es: ¿cómo hacer esta tarea pendiente de que la sociedad ayude a las personas que transitan por la enfermedad a construir su propia metáfora, una que se genere desde sus propios significados y vivencias? Muchas gracias.
Thank you very much, Mara. Dr. Mara, it's been wonderful to hear your very, very thoughtful presentation. I'm going to move on to Dr. Anna Sonkin. Dr. Sonkin is a parent of a pediatric cancer survivor and a pediatrician and a palliative care physician currently working at St. Jude Children's Research Hospital. She also specializes in clinical communication skills education. Until 2022, she lived and worked in Russia and now lives in New York. Over to you, Dr. Anna Salkin.
Thank you, Julia, so much. I have one correction to make. I do not work as a pediatrician or palliative care physician at St. Jude. I work as a coordinator in the global department. This is actually a very big moment for me, I have to confess. This is probably going to be the first time that I am talking from a parent perspective, as a parent of a survivor, or a better term that I heard recently, person with lived experience. I think that also takes us further away even from the war metaphor, which I also don't like. So I am going to be sharing my personal story and kind of trying to weave in some of my professional reflections. So bear with me, I am nervous. So my title today, can you see my screen? Is See One, Do One, Teach One, which for those of you who maybe don't know, is a phrase that is used a lot in clinical medicine education. So for various skills, I think it came from surgery, right, Julia? So, and it just means that the best way to learn something is to see it done, then to do it, and then to teach it. So this kind of corresponds to the path that I had, and I'm going to share with you. So before coming to St. Jude, when I was living in Moscow, I was first, a clinician. So it so happened that I had a dual role, which is weird. It's not a very frequent combination. So I did palliative care in a pediatric neuro-oncology clinic, and I did general pediatrics. So you can imagine you see patients who have terminal illness, and you also see absolutely healthy children. So then I became an educator. I got very interested in communication skills. I think that came also from the palliative care education that I had. And I did a lot of work in order to be able to learn how to teach clinical communication. And that's what I've been doing for about 10 years now. And then not so long ago, so it's been 5 years since diagnosis, my daughter was diagnosed with a brain tumor when she was 15 years old. So I'm going to talk a little bit from those three hats that I have as a clinician, educator, and parent. So interestingly, in my clinical work, obviously, it seems like these are two very different clinical settings where the communication challenges are different. So in palliative care, the communication bits that you focus on are like obviously delivering bad news, but also advanced care planning, symptom management, consulting on the parent-child communication. So that aspect of whether you talk to a child about their disease or you hide it from them. And in general pediatrics is more about anxiety around infections and vaccines. There's a lot of history taking because you're involved in diagnosing conditions. There's a little bit more of structure and timekeeping because you have a busy clinic. You have to really make everything happen on time. Interestingly, when I started teaching, I found that a lot of things that we can teach are actually the same process skills that apply in any clinical setting, and in fact, outside clinical medicine. I'm not going to talk a lot about what's on this slide. This is just the model that we used in Russia to teach. And it was created specifically to get together all the research that exists. Of course, all this research was from Western Europe, the States, Britain. So we have to be really careful about how this applies globally. But to get all that research together to understand, can there be a model that can be used clinically wherever, like in any specialty, in any setting? And that was very important, I think, in my work. The story that I'm going to tell you today is about the relationship building part of this model. So that's not the only, but one of the important objectives of a consultation, of a clinical encounter. We talk about building trusting relationships, creating a safe environment, working with stress and uncertainty. And I know Dylan is here. Thank you for coming, Dylan Gratz, who is from the Culture and Communication Program at St. Jude Global. And she's been doing a lot of work to try to understand those domains and what are the different functions of communication. And a lot of that is around relationships. So when you teach formally, you have a group of clinicians, doctors, nurses, and you think about what are the skills of relationship building that you want to teach these people in various ways. There's quite a list. Like there's some nonverbal communication, there are techniques about questioning and listening. There are ways where you can elicit ideas, concerns, expectations, acknowledge them, show empathy, give tailored information giving, shared decision making. There's quite a lot actually that you can focus on. And it was very interesting for me to teach that. And I did that in a simulated environment. So we did either role play or analyzing videos, or my favorite, simulated patients who are professionals, know how to give feedback, understand what the skills are. So having worked for a long time with this, come 2019, and everything changes. So my daughter, after having some symptoms and going through an assessment, is diagnosed with a brain tumor. She was treated in this big hospital, which is the main federal center for neurosurgery in Moscow, you would think. It was a very cold, lonely, and even cruel sometimes place. And this sign over here really shows the atmosphere that was there. In a dark corridor, there was this door, and somebody put a sign saying, "There is no one here." And that really reflected the loneliness that we experienced in that hospital. So what I'm going to talk about specifically is the radiation consultation that we had after her tumor grew and she needed that next phase of treatment. So if you were to ask my daughter, how did that consultation go? She would say, "Oh my God, it was terrible." But what went wrong exactly? And because I've been teaching, a lot of teaching involves observing. When you teach, especially experientially, you're observing what people are actually doing. So if you try to break down what exactly happened there, it was a dark room. So the physician didn't turn on the lights after looking at lots of images. There's absolutely no eye contact the whole time he was looking at a screen. No facial expression. He did not introduce himself. There were these long silences where he was typing on his computer. There wasn't any clear structure, so we didn't understand what was going to happen. How much time did we have? Do we need to ask questions? Do we wait? We couldn't understand what to do. And there was absolutely no room for questions. And when I was preparing for this webinar, I know that a lot of us as parents and people with lived experiences, we think about communication and about the ways we can change that, the way we can influence how medical professionals communicate with us. So drawing from my teaching experience, I've been thinking about how we can bring what we know from educational theory and research into this kind of environment. And the most effective way to change people's behavior is to give feedback, whether it's direct feedback to the person or it's some sort of like unified, summarized feedback that you give to the medical institution, for example, or even wider, the feedback that we give to the wider community when we tell our stories during events like this one. So what we know is that for feedback to be effective, it has to have certain qualities. It has to be specific. It can't just be, "That was terrible. They were bad to me." It has to be descriptive. It has to be pointed at something useful, so something that could actually be changed. And a lot of the times it helps for it to be strengthened with some kind of feeling of emotion or reaction or thought. So what do I personally think about this or feel about this? And I'm going to give an example in just a moment. So what I'm inviting all of you to do is, if we decide to give feedback, how can we think about the interaction or the group of interactions that we had and think about what are the specific behaviors that we observed? I actually think this could apply to society and all those things that we've been talking about, that we would want to give feedback to the wider community, right? About that war language, about stigma even. So what are the specific behaviors that we observe? Which ones of these behaviors can actually be changed? What was the most important issue? And this is a very important point because people don't receive a lot of feedback. That's important to know. If you give them a lot of feedback, they're just going to be overwhelmed. So what's the 1 or 2 most important things that we want to give feedback on? And actually, how did that make me feel specifically and why? Is it just that I know that that's wrong, or I can actually share what that did to me and why that's an important? So if I think about that structure, I'm thinking, I'm going a little bit over time. I'm sorry, probably just a minute. Sorry. So it might be something like, depending on what's important to you, they or you did not introduce themselves, did not invite me to ask questions, so I felt disrespected and dismissed. Or it was dark in the room, they were looking at the computer the whole time, never once looked at me. I felt uncomfortable and scared. My personal one, if I had a chance to give that feedback, maybe I did, but I was just scared to do it, to be honest. My one would be this. You did not tell me what was going to happen in the consultation. There were long periods when you were typing in silence. I was stressed because I didn't know whether to speak or to wait. So I don't know if you also feel that this applies, that we can use this somehow in our practice, in our work, in our advocacy work, in our teaching work. I just wanted to share this. And the last thing that I wanted to show you, and I think, Guillermo, I saw you there. So last week we were in Japan, in Yokohama at SIOP Asia, and I, of course, was sitting in all the CCI meeting sessions. And I was asking some questions about my daughter, specifically in the survivor session, and they were so kind to me. So I just wanted to show a photo of these amazing young people who came to me after the session, hugging me and asking about my daughter and giving advice, sharing their contacts, and even sending her the little gold ribbon pin that everyone has. So thank you very much. And here's my email in case you have thoughts and ideas of how we can maybe use all of this, or maybe you don't agree and have other ideas. Thank you so much again. It's a big moment for me. Thank you.
Super. Thank you so much, Dr. Anna. It's been a pleasure to listen to your very thoughtful presentation. And I think your advice was clear and direct, and will maybe give other people ideas of how they can communicate better as well. I'm going to move on to Chris Koba. Dr. Koba Chris Koba Munjba from the Democrat. Sorry, you say it, Chris, because it should be right. Can you say it?
Njumbe is a African Congolese name.
Thank you. I did better the first time I tried when we first met. I apologize. Dr. Chris is a public health expert and associate professor at the University of Lubumbashi in the Democratic Republic of Congo. He specialized in the studies of quality-adjusted life year and disability-adjusted life year and cancer costs in Africa. Of Congolese origin, he studied medicine in Lubumbashi. He's a member of the Groupe Franco-Africain de Oncologie Pédiatrique. We know it as GAFOP, and SIOP International. Welcome, Chris. Go ahead, over to you.
Thank you, Julia. But I have a great privilege to share with my friends in the field for my experience to oncology. But my topic is stigma of cancer survivor psychology experience of the parent of childhood cancer in survival in Lubumbashi. According to the data information collecting, today cancer is a diagnostic and survival rate for childhood cancer have increased because of improved treatment protocol around the world and in the Republic Democratic of Congo. Most of children arrive before we lack enough to live with cancer, but stigmatization is described the negative and attitude use of support by ignorance. And good communication has a positive effect of health outcomes. This study we do in Republic of Congo Congo is a big country in the center of Africa, but we have 99 million people who live in Congo, but this statistic is for 2020. 46% of this population, they are child before 15. DRC is a large country of sub-Sahara Africa, and 2.3 million square in kilometer is like West Europe. But 15 million live in Kinshasa. Kinshasa is the capital, but is the most population is in Africa, city in Africa. And we found 610 per woman as a fertile rent. But we have a different type of stigma in DRC, and this stigma we found in the field, but we know that the young people who have survived in cancer are medically vulnerable population due to the physical impact of treatment, which can result hair loss and screening the change mobility emotionally and social imperfect resulting include the stigma which may be experienced on 3 types of stigma. But we found 3 types of stigma. The first one is public stigma. In public stigma, we found the example like a limitation of participation in social life. In family stigma, we found a bad luck. And the self-stigma, we found in the field the loss of hope in life. But
Excuse me, Chris, sorry, excuse me, Dr. Chris, can you advance your slides? I think you're talking about your next topic. Can you move the slide?
Yes.
There you go, thanks.
But I say we found a different type of stigma in our field, but the first one is a public stigma. We found a limitation of participation in life, social life, exclusionary attitudes, and community segregation. But the second one is family stigma. We can go family stigma, and in the family stigma, we found the bad luck and curse and punished from God. And the third one is self-stigma. In the self-stigma, we found a reduce of quality of life, less adherence to belong, and reduce self-esteem and lack of power to act. But in our environment, we have a common appellation used for the cancer. The common appellation for the cancer is saratani. Saratani is in Lingala and Swahili. Swahili and Lingala is a local language in DRC, but we use Saratani like to call the people who have a cancer. But Saratani is a Arabic origin name, and the people who is survived with cancer in Lingala, we can call them Dongolo Bisu, like enemy and wizard. That the name who they are, these people who survive with cancer, we call in this country, but the people speak Swahili and Lingala. But many progress and approach to change. Many parents feel frustrated about the look of support their child to initiative support strategy for a good communication and creation of friendship group in community help the financial crucial role in ensure that the children receive the necessary cancer treatment, the urgent need for better psychosocial support for the parent of children, and call specific health police to combat the stigmatization of pediatric cancer in DRC Congo. And we recommend a comprehensive support system, including medical psychosocial assistance to improve the well-being of affected families. But now, I need to ask us to take a few minutes to watch this video testimony from a survivor mother of children.
Mie ni Professeur Koba, niko munganga ku clinique universitaire ya Lubumbashi na mi natumika mu santé publique, na beaucoup plus ni unaangalia wagonjwa wale weko na kanser, kuangalia magonjwa yabo na kuishi kwao tangia ile siku balidiagnostike malari ya kanser na kupitia traitement yabo na kama banapona au wale watakufa, ile yote tunajifunza wakati kanser.
Asante sana doktor. Huyu mtoto yangu tuko sasa na 2 ans. Niambia mtoto huyu wangu yuko na kanser. Ile saa milisikia kio mtoto yuko na kanser, mili huzunika sana. Ninaangalia aji yake 5 ans, mtoto na kanser. Deja miliona lufu. Pale mimi naona mtoto vile na huzuni sana, paske mimi naanza kujiuliza, mtoto wa 5 ans na kanser, hii malari hii ni ya demo? Hii malari inatokea wapi? Paske shi bote tupale si tulikome atukuiweke kanser mu 5 ans. Hapana, hii ni paka tu demo. Hii malari mimi shichikie, paske mfamilia yetu hakuna hii mtu kuna ile malari inatokea wapi? Sasa pale nitaenda kuonesha baba yake, njoo mimi si US vile babake na yata siki.
Sawa. Sasa mimi nitakuuliza pale balinionyesha aseme muna kanser, mulitikia aseme ni malari, mtu anaweza.
Wonderful. Thank you so much, Chris. Do you want to please thank the mom for sharing her story with us from the DRC? I really appreciate
it. Thank you.
So that is the end of our presentations from our professionals working in the area of communication and stigma in childhood cancer. We do have a question in the Q&A. I want to ask Dr. Anna, it's directed to you. Dr. H.K. Das says, what has changed after 2019 onwards till date towards palliative care and in the communication skills from the healthcare providers? Have you noticed anything since 2019? I think this is probably post-COVID.
In Russia, or
why don't you just say whatever you prefer that doesn't specify?
I really don't know, honestly. I don't know how to answer that question. I would expect it to, I don't know, I can imagine some things becoming worse, well, less effective. But I can also imagine some things becoming better, because with COVID, like something that I noticed actually when we were all wearing masks, remember at first you could never tell a face expression. And then we started looking at each other's eyes more, right? And we started noticing and picking up those nonverbal cues better. So I think we learned a lot from that experience, and also a lot started happening online. And all this distant communication forces you to find ways to verbalize things that used to be only nonverbal. So I don't know. I think there might have been more things that we learned than lost.
Thanks so much. Do any of the other three have a comment about post-COVID or what you experienced during COVID and communication? Dr. Yamini, do you have any thoughts in India about what that was like?
I can't find any difference, but definitely, as Anna said, most of us have our masks on now. Still, the communication skill has gotten better only. So definitely we are giving more non-verbal cues to people through our gestures. Probably eye communication is better. So definitely I think our communication skills are getting better. No doubt about it. And probably the emphasis on communication is more now. I don't know whether it's because of legal issues that are increasing and doctors are more aware of the need for communication. Previously, the only term we used to hear is, let's see. Now we tend to give, more information to the patient, get their input on what their, perception is on the disease, what they want. It's a combined effort to treat the child, as against previously when the sole treatment would be taken by the primary, doctor, rather than the parents and the child. So I think probably that's the difference that I have seen over the years.
That's wonderful. Thank you for sharing that. Dr. Mora, do you see a difference now recently after COVID with how people are receiving or health professionals understanding communication?
Bueno, no encuentro grandes diferencias que no se hayan trabajado con el diálogo, porque si bien, por ejemplo, durante el COVID, a mí me costaba mucho trabajo como psicoterapeuta, pues estoy acostumbrada a contactar mucho con las personas y a leer todo su lenguaje corporal y no verbal. Entonces era muy difícil y yo de hecho siempre hacía el gesto de retirarme el cubrebocas para que vieran mi cara y me lo volví a poner. Pero eso, el usar esta parte y cubrirnos la mitad de la cara, definitivamente nos orilló, nos obligó a contactar con la mirada. Y creo que eso fue un avance digamos, en la comunicación médico-paciente, porque los médicos efectivamente, como decía Ana, a veces ni siquiera miran a la persona que está frente. Y el trabajo que hemos hecho en psico-oncología y que hacemos todos alrededor del mundo es precisamente humanizar este trato, ¿sí? Decirle a los profesionales que también son personas y también son humanos, cómo comunicarse y cómo acercarse y hacer contacto sin que sientan que pueden ser lastimados, porque muchas veces eso es lo que hay en el fondo. El COVID nos puso en evidencia que lo vulnerable que somos, y creo que eso fue algo que, ese sentimiento compartido, creo que fue lo que ha permitido que avancemos un poquito en vernos como eso, como personas.
Thank you. Mil gracias, Dr. Mora. Mariah, if you allow me, may I allow Chris to answer this one question and steal 1 or 2 minutes from your section? Thank you.
Sure.
Dr. Chris, thanks so much. Dr. Chris, did you see a difference after COVID in how the patients were thinking about cancer or the stigma of cancer, or did you see any changes after COVID?
Yes, of course, we found a difference before COVID and in COVID and after COVID. After COVID, the people can go in the contact with another people, and the people can see the stigmatization because the people go out. But in COVID, the people don't go out and stay at home, and this patient say is not find too much stigmatization. But after COVID, the contact with another community, another people can do this attitude for a new stigmatization for the community.
Thank you so much for sharing your experience from DRC. So that concludes the professional part of the presentations for the first hour. We're going to invite the professionals to stay with us if they have the time, because if other questions come up, they're welcome to give an answer. And I'm going to turn the microphone over to Mariah, who is going to be the moderator for the next hour and for the roundtable with those who have a lived experience of childhood cancer. Mariah, over to you.
Thank you very much, Julia. Just getting my slideshow set here. Okay. Thank you. My name, as Julia said, is Mariah Forster Olson, and I am from La Crosse, Wisconsin in the United States. Wisconsin may be most renowned for our professional sports teams, such as the Green Bay Packers, which is American football, the Milwaukee Brewers, which is our baseball team, and then the Milwaukee Bucks, which is our professional basketball team. It is a privilege and an honor to be here today moderating this panel and to speak about childhood cancer survivorship and stigma. I am also a survivor of childhood cancer. I was diagnosed with neuroblastoma 44 years ago in 1980 at the age of 1, with a tumor growing out of my spine, wrapping around my heart and pushing against my trachea and lung, making it difficult to breathe. I was given poor odds of survival, but I had surgeries, radiation treatments, and 2 years of a brand new experimental protocol for chemotherapy, which ultimately saved my life. Due to the location of my tumor and outdated therapeutics, I have around 100 different long-term side effects and late effects. I've had 52 surgeries, and I am at a higher risk for 9 different secondary cancers. I have experienced stigma from having cancer, especially because I was treated so long ago. It was so difficult, but I had to break through it in order to reach my goals and be happy. For example, I am almost finished writing a book about my life with Bell Asteri Publishing titled Hope Over Despair that focuses on hope, optimism, and positivity. I am also involved with several childhood cancer nonprofits, including the Neuroblastoma Children's Cancer Society, the Gold Together, which is the American Cancer Society's Childhood Cancer Initiative, the American Cancer Society Cancer Action Network, and I am the survivorship lead and board secretary for the Coalition Against Childhood Cancer, or CAC2 as it's abbreviated. I find fulfillment in giving back, and it fills my heart with gratitude and helps me remain positive and hopeful. I also play the oboe, and I enjoy getting my emotions out through my music. Additionally, I love spending time with my family, my husband Troy, and our Siamese cat Isaac. Before we get started with the panel, I have been asked to share a new program from the Coalition Against Childhood Cancer Survivorship Interest Group, which just launched in January. I am so proud and excited to introduce the CAC2 Survivorship Toolkit, co-led by myself and Mary Beth Collins, which provides education and resources for childhood cancer survivors and their families all in one place that address some of the challenges and issues that are faced during survivorship. As we have learned, childhood cancer survivorship is growing, but there is little information available for survivors and their family members. Although there are some wonderful survivorship toolkits that exist, they typically focus on a few key topics. We do not want to recreate the wheel, so we will highlight the organizations who have addressed things well, but we also know that we will have to create content. Survivors and their families often have several issues to contend with post-treatment, including late effects, finances, family relationships, and the emotional impact on every family member. Current information is readily available in the following 6 categories, which are listed here: educational guidance and planning, insurance and financial health, physical health and late effects, psychosocial and emotional health, transitioning to adulthood, and wellness and healthy behaviors. The CAC2 Survivorship Toolkit draws together expertise from professionals and experienced advocates to create a dependable library of resources and provide guidance along the survivorship journey for survivors and their families. And you can access the CAT2 Survivorship Toolkit using that QR code on this screen. So now I will stop sharing my screen and we will introduce our survivor panel today. Is Anna here then?
Yes, I'm here.
Okay, great. Hi, Anna. Anna is originally from Romania, but now lives in Germany. And now, Anna, you can further introduce yourself. Thank you.
Thank you so much, Mariah, and it was really great to hear also the projects that you are involved in and the impact that they have. As Mariah mentioned, I'm from Romania. I'm a cancer survivor myself. I was diagnosed with non-Hodgkin lymphoma, and during my treatment, I started to be really interested in the medication that I was receiving and why I was receiving the medication. So after completing the treatment, I finished school and started a biomedical science degree. I'm currently living in Germany and I did my degree in UK. So I had the opportunity to experience healthcare systems in 3 countries and to observe the differences that exist in the care present both in Eastern Europe, in Romania, and in Western Europe. Yeah, and that's pretty much everything from my side, and I will leave Mariah to introduce the next survivor. Thank you so much.
Thank you so much, Anna. Charlie is from Guatemala, and he was diagnosed with acute lymphocytic leukemia at the age of 18. Now Charlie will further introduce himself.
Hola, hola a todos. ¿Cómo están? Voy a hablar en español. ¿Pueden ver ahí mi pantalla? Bien, ok, bueno. Hola a todos, yo soy Charlie Ramírez. Yo soy un sobreviviente de cáncer y fui diagnosticado con leucemia linfocítica aguda a los 18 años. Estuve en tratamiento alrededor de 3 años y quiero contarles un poquito acerca de mí. Pongo aquí la foto de mi familia porque ellos son parte importante de mi motivación todos los días. Y yo soy cristiano y aquí tengo una foto de mi familia, mi esposa y mi bebé hermosa que tiene 6 meses. Actualmente yo trabajo como gerente de proyectos de tecnología, como lo comentaron. Yo soy de Guatemala y una de mis pasiones o hobbies es tocar marimba. Lo pueden ver ahí en el número 5. La marimba es el instrumento nacional de Guatemala. Y por último, en el número 6, esa pasión por la marimba también me lleva a, junto con mi esposa, a crear un canal de YouTube que se llama Marimba para Todos, en donde enseñamos a tocar marimba al estilo de Guatemala. Y quiero contarles un poquito acerca de Guatemala. Ustedes pueden ver ahí la bandera de Guatemala. En el número 2, estamos ubicados en Centroamérica. Somos vecinos con México, Honduras, El Salvador y Belice. Digamos, estamos ubicados en la región de Chiapas, Guatemala, Honduras, en donde se originó la cultura maya. Ustedes pueden ver ahí en la imagen número 3, está Tikal, que es uno de los lugares emblemáticos de la cultura maya. En nuestro país, en la imagen 4, pueden ver la marimba, es nuestro instrumento nacional, orgullo nacional. En el número 5, yo les puse ahí algo bien bonito de nuestro país y es que comemos muchas tortillas. En general, comemos mucho maíz. Y en el 6, uno de nuestros platos tradicionales es el tamal, le decimos en Guatemala, que es también hecho de maíz. Pero para que conocieran un poquito de la cultura de Guatemala, mucho gusto a todos y espero compartir un poquito de nuestras experiencias.
Thank you so much, Charlie. Now Raja is received treatment for leukemia at 9 years old from a cancer center in Lebanon. Raja, will you please further introduce yourself?
Yes, hi, I'm Rasha Hajar. I'm from Lebanon, and I was diagnosed with leukemia when I was 9 years old. I was treated actually for 4 years. I finished my treatment in 2007, and it was at the Children's Cancer Center in Lebanon. And now I moved to Montreal. I work actually in a cancer center also. It's been for 2 years, but the difference is with adult patients. But my purpose was only to help the patient because I know their experience. It's hard, especially for the adults now, because some of them, they have family, they have kids, so it's hard for them. So yes, that's it.
Thank you so much. Now Minar was inspired by her personal cancer experiences to pursue a career in medicine. Minar, please tell us more about yourself.
Hi everyone, my name is Minar. I'm 24. I am 24 years old. Can you see the presentation? No?
Not yet. There, it's.
Vous avez lancé le partage d'écran. Les participants peuvent maintenant voir votre application.
So I was saying that my name is Manar. I'm a 24-year-old medical student living in Rabat, Morocco's capital. Rabat is the capital of Morocco, and it's one of the 4 imperial cities in Morocco. It is known as La Ville Lumière, which means the city of lights. It is located along the Atlantic Ocean coast at the mouth of Bourgreg River, and it's providing scenic views. At the age of 10, I was diagnosed with Hodgkin lymphoma. I did my chemotherapy and radiotherapy here in Rabat, and this year I celebrated 14 years of being cancer-free. Inspired by the care and dedication of the medical professionals who treated me, I decided to pursue a career in medicine. And now, as a medical student, I am committed to make a difference in the lives of my future patients and to support and heal those in need. Thank you, everyone. That was all.
Thank you so much for that, Minar. And now our final presenter is Kenneth, who is one of the founding members of Ahava Childhood Cancer Care Uganda, and his daughter Gabriella had leukemia at 2 years old. Kenneth, would you please introduce yourself?
Thank you very much. My name is Kenneth Nganda, and I am from Kampala, Uganda. Uganda is a country in the eastern part of Africa. It lies right by the equator. So in 2019, my daughter, Gabriella, who was 2 years old at the time, was diagnosed with acute lymphoblastic leukemia. At the onset of the COVID-19 lockdown in our country. So the day that the lockdown was announced, we were going to hospital to start chemotherapy. And we have walked a journey of all these years to date of treatment and of care, like many of the survivors can attest, a gruesome journey. But nonetheless, here we are. We moved on from that part to trying to inspire parents like myself. And we started together with other parents, Ahava Child Cancer Care Uganda. It is only one of 2 parent support groups that we have in the entire region here in Uganda. And I am so honored to be a part of this. Thank you, everybody, for all the survivors, for your amazing stories and testimonies. Thank you. Yeah.
Thank you so much, Kenneth. And now I'd just like to remind everybody that if you do have a question for this group of survivors, you can put that in the chat. Just checking to see here. So let's start with
Mariah, can I just make a quick question before? I just want to direct Chris, can you look at the Q&A because there's a couple of questions for you there. So if the professionals could look at the Q&A and just monitor people are asking questions there, you can answer with the little blue button. Thanks, Maria. Sorry for the interruption. Go ahead.
No problem. So we do have a question in the chat from Dr. H.K. Das, and that is, how does the societal role in your settings, so each of your countries where you are, deal with how does the societal role in your settings deal amongst the cancer survivors with regard to stigma? So I'm going to start with Rasha, would you mind answering that first?
Yes, of course. Actually, during my treatment, it was a little bit hard when I go outside in the society, because being I have a bald head. I don't wear any hats, so they were like looking at me and feeling sorry for me, because for them during my treatment, it was like, if you have cancer, that means you're going to die. So, and also when I was going to school, because I didn't stop going there, some of my friends also, they treated me differently because of me being diagnosed with cancer. So yeah, but now it's much more different, because there was so many explanation about cancer. So they know more. So it's much more better than before.
Thank you so much for that answer. Charlie, would you like to take a stab at answering that question?
Sure. Creo que en mi país, voy a hablar muy puntualmente de mi país en Latinoamérica, Guatemala, hay falta de conocimiento y de qué significa, digamos, esta enfermedad, de lo complejo que es. Y lo vi en las presentaciones pasadas, digamos, hay culpa, digamos, en su momento, cuando uno es diagnosticado, porque uno siente por qué, ¿verdad? ¿Por qué yo fui diagnosticado con cáncer? Y muchas veces la sociedad, siento yo, en mi caso muy puntual, no entiende, digamos, lo complejo o lo profundo de la situación y lo que uno llega a sentir. Así que al inicio yo en mi experiencia personal es un poco solo, ¿verdad? Porque uno con su familia, uno se siente como nadie me entiende en realidad, porque no saben lo profundo ni lo complicado que es esta, esta situación. Y lo voy a decir así, por el otro lado, luego también uno encuentra muchas personas que, a pesar de que no llegan a comprender la complejidad, están a la par, ¿verdad? Entonces hay de las dos cosas, ¿verdad? Y por un lado, tal vez la falta de comprensión y la falta de conocimiento, pero a pesar de eso, uno siempre encuentra personas que están ahí, ¿verdad? En todo sentido, familia, amigos, doctores, enfermeras, ¿verdad? Enfermeros que siempre están ahí al lado de uno, escuchando, comprendiendo y apoyando.
Thank you so much, Charlie. I think that was a very important point about the feeling of guilt. That was a very important call out. So nice job with that. Minar, would you like to answer that question next about how stigma plays a role in your area, in either where you're located?
Yes, of course. As a childhood cancer survivor, I had my fair share of stigmas, of course. I faced avoidance at school, also from some family members. They wouldn't let their child play with me because they viewed it as contagious. And I also was bullied at school from my physical appearance, in the streets, at the supermarket, like everywhere. Yeah, so I know that childhood cancer, childhood cancer is difficult, and children who are receiving treatment, they're already fighting a disease that is affecting them. So the last thing they want is to feel rejected by community. And this can lead to difficulties with social reintegration, and it can negatively impact their mental health. That's all.
Yeah, thank you very much. I can relate to the bullying aspect of it, and I think probably all of us survivors can relate to that. We did have a question come in for Kenneth, specifically for you. So the question is, I am also a survivor of ALL from Tanzania, and my name is Calvin. I was asking, what are the challenges to many parents in Uganda when it comes to childhood cancer in the aspect of taking their kids to the hospital?
Thank you very much, Calvin. My brother from neighboring country in Tanzania. Our challenges in the region are pretty much the same. With our experience here in Uganda, cancer is a very financially limiting illness. As a parent, personally, I had to give up my work to be supportive to my spouse, my wife, and the mother of my child. And because of that, you're spending all the money and all the savings that you have. And this is the same that we see for other parents as well here in Uganda. Many will abandon treatment for lack of transportation. Until recently, the only cancer center we had at the Uganda Cancer Institute was in the capital in Kampala, which for many parents is over 400 or 500 kilometers away. So they can't even afford transportation to come to the clinics. And even when they do, they're not able to come back for the follow-up visits because of limitations with finances, limitations with food, which face challenges even with just the food and feeding patients here. We face challenges with accommodation. It's a shame, but until recently, patients at the hospital where we got treated were sleeping on the veranda and in car parks. You know, the hospital had to improvise with tents. And it's still partly the situation, although there are a few improvements. So there are various challenges. I just only highlighted a few of the challenges that we would face to bring children for treatment. Many of the parents will also abandon treatment because they have been told that their child is bewitched, you know, that they're going through something that either their parents have done in the past. There's a curse following their family. In my case, people try to come to us to say there's something that we would have done, or that our parents or grandparents have done, or that there's a curse. And this is usually the same for many parents here in Uganda. So we'll find parents abandoning treatment because they've been told that their children are going to be cured at the traditional healers, or some are even going to church and being deceived by religious leaders, you know, that it's a curse from God. Cancer is a curse from God, and that they only have to come to the church. So just some of the challenges that we are facing here with parents in bringing their children for treatment. Thank you.
Thank you very much for that, Kenneth. Very enlightening and scary and sad circumstances there. We do have a question here. How can SIOP and CCI address any stigma related to childhood cancer across the world? And what actions can we take to address it? I'm going to start this time with Manar, please. Would you mind answering that question?
Yes, of course. So we need to engage firstly with the cancer survivors and their families and healthcare providers and communities to understand manifestations of stigma across cultures. And then we need to raise awareness by launching global and local awareness campaigns to educate the public about childhood cancer, its causes and its treatment, and using social media and community events, celebrity survivors, and then we need to integrate models on childhood cancer into school programs to educate children and teachers.
Thank you. I'm sorry, please continue.
Yes, of course. And then we need to improve healthcare professional communication skills regarding the childhood cancer. That's all.
Thank you so much for that very thorough answer. That was a great job. Anna, could you please answer that question of how CCI and SIOP can address stigma across the world and the actions that we can take to address it?
I think, first of all, by what Manar mentioned, engaging with the patient community and with the people that have lived experience. I think there is an opportunity also to collect patient experience data and advocate using that data, and increasing the access to support services that childhood cancer patients and survivors should be able to have by having awareness campaigns, because as it was already highlighted, there are lots of misconceptions in regards to the causes of cancer, what people are experiencing, and also when people return to school. I think there is a need to educate the pupils that are in school in regards to cancer, so that when a cancer patient is reintegrated back into the school, there is not that misconception that the cancer is contagious, what Manar mentioned, and I also experienced when returning to school. Then there is a lack of awareness regarding the body image for which you are bullied. So if there would be programs that educate students in regards to cancer and normalize the concept of the disease and not minimize it, but acknowledge that it can happen and that the people that are back to school need a little bit of support. And I think there is also, when we're looking at school, but also the general population would need to be educated in regards to this. And I would say also in regards to healthcare professionals, I think one of the aspects that I would highlight is the communication that healthcare professionals should develop when interacting, communication skills when interacting with a kid, because most of the time the communication happens between the healthcare professional and the parent. So you are never building a relationship with your doctor, and you're never aware of what actually happens with your medication, with your treatment, and with your care. And out of a sudden, when you become an adolescent or a young adult, you're forced to learn about all of these aspects by yourself from zero, without having any backup knowledge and having to manage your own disease, which can be challenging, especially if you're moving away from your home country and you're forced to manage everything by your own, and your parents are not there to guide you in this transition. So I would say these are a few aspects that SIOP and CCI could work on together with the patient community and with the society.
Thank you so much. Charlie, did you have anything that you wanted to add to this question at all?
Sí, gracias. Yo agregaría dos cosas que, para ser muy sincero, encontré acercándome a este grupo. Y uno, creo yo, es compartir las historias, porque, como les decía, tal vez en mi experiencia personal en Guatemala, me sentí solo al inicio, ¿verdad? Porque como hay mucho desconocimiento, ¿verdad? Del cáncer, es más, yo no conocía a nadie en su momento que haya pasado por cáncer. Cuando me diagnosticaron, mi familia empezó a conocer muchas personas alrededor, ¿verdad? E historias, y eso me motivó, pero no existe algo, lo voy a decir así, como tal estructurado, ¿verdad? En el que realmente uno pueda saber dónde ir a buscar otras experiencias, otras personas, pero eso de verdad creo yo que motiva mucho, digamos, el generar esa comunidad y comunidades pequeñas, ¿verdad? Comunidades pequeñas en donde pueden encontrar apoyo. Muchas veces solo el apoyo de compartir, ¿verdad? Y estar a la par y de saber que no estoy solo, eso ya da mucho confort. Y le da a uno esperanza de saber que no estoy solo, y es más, el compartir eso lo alivia a uno mucho, ¿verdad? Al hablarlo, al contarlo. Entonces creo que generar esas comunidades pequeñas, ¿verdad? En cada país, y no solo centralizadas, digamos, por ejemplo, en mi país seguramente hay mucho centralizado en la capital, en Guatemala, y hay que abrirlo, ¿verdad? Para poder llegar a muchos otros departamentos dentro del país, para poder llegar a escuchar y generar esa comunidad a todas las personas que realmente llegan a enfrentarse con esa situación.
Thank you so much for that. Now we're going to move on to the next question, which is from Dr. Sonkin, who spoke earlier. Her question is, how did the experience of stigma affect your decision to share your lived experience publicly, like at an event like this? So I'm going to start with Kenneth this time to get the parent perspective of a survivor. Kenneth, would you like to answer that question?
Yeah, thank you very much. If I understand the question very well, for me, because of the stigma of our daughter, I developed an anger within me because we felt that we had a story to share that was valid. We didn't want that I had cancer, and we didn't bring this on ourselves, you know. I didn't like everything that was being said about, you know, having a curse or it being from my parents. First of all, it didn't make sense and did not resonate with me and my wife. And so out of anger, I remember we sat down and said, what can we do? And then we said, we are not going to hide. You know, many parents do hide. I remember going through treatment with parents who did not want even the word cancer to be mentioned in the same statement with their child. So out of an anger, developed a desire to share our story in an explosive way, to do something. And it started simply by the need for blood. Our daughter did not have blood because of COVID-19. There was a lockdown, and blood in Uganda is sourced mostly from secondary schools and universities. They were under lockdown. So we started by mobilizing people within our immediate family to walk to the blood donation center. And people walked, I'm telling you, 5, 7, 10 kilometers. They were riding bicycles when they heard of the story of our child to go and donate blood. So it started off in that simple way. And then we felt that it was upon us to then share her story and inspire many other parents, some of whom were afraid to speak out, but then others also who did not just have a platform. So it started off simply like that for us. And slowly we graduated into a huge blood donation campaign. As I speak to you now, we have over 4,000 registered blood donors that have gone to the blood donation to donate blood. And we use that to share about childhood cancer, the fact that it is real, but that, you know, there's help and there's cure. And it also then graduated into a parent support group where we are sharing with other parents and encouraging them to speak out, you know, and walking the journey with them and just sharing the truth. We also discovered there's so many lies, you know, and the truth has been powerful. So for us, the effect turned from anger to being positive and desiring to share. Yeah, that's our experience. Thank you.
Thank you so much. Rasha, from a survivor point of view, how did the experience of stigma affect your decision to share your lived experience publicly?
Honestly, it doesn't affect me negatively. I feel proud of myself telling other people that I had cancer and I'm a survivor now, because it's not my fault that I had cancer, so I should be ashamed. It was a good experience actually at the same time because it made me stronger, made me much more stronger. And yeah, so I don't feel ashamed at all. And I tell every new person that I meet or is having difficulty, is just that got diagnosed with cancer, I tell them the truth, and I tell them that I also had the experience. It was a long journey, but look, it's something positive. I'm working now. Everything is good. It's not something to get ashamed of.
Thank you so much. That's a wonderful perspective and great to feel pride about it. To be proud that you're a survivor, that you made it through. Minar, would you also like to answer this question?
Yes, of course. At first, I wasn't really proud of my cancer journey. I didn't tell anyone, not my friends, after high school and that. But recently, I started telling people that I had cancer when I was a child, because as Rasha said, it's not my fault. I didn't do anything. It happened. That's pretty it. Thank you.
Thank you so much. We now have another question here from Julia. How can the survivors share an example of when someone said something that was helpful during their treatment? or said something that made them feel supported, and can they tell us that story? So we're gonna start with Anna on that one, if that's okay.
Yeah, sure. I was trying to recall, and sadly, I do not think I can recall anything that truly was that supportive statement that helped me push through. But I would say what helped me definitely throughout the treatment, it was the psychosocial support received during the hospitalization, and receiving mental health support from the point of diagnosis, during the treatment, and after the treatment, in order to be able to reintegrate, and also to have explanations for what I'm going through, why I'm going through things. Obviously, they were not medical explanations, but I think that's what helped me throughout. It was not a statement, but it was the constant support received from a professional.
Thank you so much. Anna, I'm sorry, Charlie, could you answer that question next, please?
Sí, seguro. Yo tengo en mente dos experiencias que me ayudaron bastante. La primera fue de mi doctor, el pediatra oncólogo que llevó todo mi tratamiento. Y lo voy a decir así, yo tenía 18 años y él me animaba y me trataba como un niño. Y la verdad es de que esas pequeñas cosas que él hacía, ¿verdad? Como chistes, bromas, aún en medio de que yo estaba en la quimioterapia, me animaron un montón. Porque yo siendo ya de 18 años, ya no un niño, ¿verdad? Me hacía recordarme lo que un niño, como un niño ve la vida, ¿verdad? En encontrar momentos felices en los chistes, en las bromas que hacía mi doctor y me animaba mucho, ¿verdad? Y hacía trucos de magia. Él hacía trucos de magia. Entonces yo estaba en medio de la quimioterapia y él llegaba conmigo con cartas y me decía, bueno, escogí una carta y él adivinaba la carta. Eso de verdad me dejó marcado el corazón. Es algo que le estoy eternamente agradecido a mi doctor. Y la otra experiencia fue con una enfermera. Me recuerdo yo que fue un tratamiento en el que yo tenía que estar 3 días de largo en el hospital. Para serles sinceros, ustedes saben que en Latinoamérica es un poco complicada la situación, entonces mi familia siempre evitaba ir al hospital porque era muy caro, ¿verdad? Entonces siempre tratábamos de tomar las quimioterapias, no en el hospital, sino en la clínica del doctor, porque era mucho más económico solo pagar por los medicamentos. Pero hubo una vez en la que sí tenía que ir al hospital y era tratamiento creo que de 3, 5 días que tenía que estar en el hospital de lleno, ¿verdad? Todo el día con la quimioterapia. Y me recuerdo que yo miraba las bolsitas del medicamento colgado a la par de la cama donde yo estaba y yo sintiéndome terrible. Pero hubo una enfermera que yo le decía, es que eso me da náuseas. Y ella vino una vez y puso una bolsita encima de la bolsa de medicamento, una bolsa de papel, y dibujaba animalitos. Entonces dibujaba la cara de un gato, dibujaba la cara de un oso. Yo creo que son cosas pequeñas, pero creo que desviaban mi atención del dolor y me hacía como voltear a ver las cosas pequeñas y bonitas de la vida. Y esas dos cosas me dejaron marcado. Estoy muy agradecido con ellos porque me animaron mucho a seguir adelante.
Thank you so much, Charlie. Manar, would you want to answer that question? You're on mute if you're, yep, thank you.
I didn't hear you.
Oh, I just said, would you want to answer the question? Can the survivors share an example of when someone said something that was helpful during their treatment or something that made them feel supported? And can you tell us that story, please?
I really can't recall right now something.
Okay, that's no problem. Rasha, did you have anything that you'd like to contribute?
Yes, of course. Actually, what helped me most is the fact that my family didn't treat me differently than my siblings. I kept going to school when I couldn't, when my immunity system was low or tired. I used to study at home and go do my exams when I can. And what also helped me is that the staff where I was treated at the Children's Cancer Center, they were like my second family. They didn't treat me like I'm a sick a child. No, I'm just here to get treatment, to laugh, have fun, and that's it. So yeah.
That's great. Thank you. And Kenneth, I noticed that your hand was up. Did you have anything that you wanted to add to this?
Yes, I did. Thank you very much. I think for me, it was two people. One was obviously my wife, because we were going through the journey together. We constantly would speak to one another, and her presence and her words were very, very encouraging. She kept saying, that everybody may be saying that this is a curse, but we know that God chose us to, for a purpose, because, we had prayed about having our child before, all this cancer came in, and she kept encouraging me to go on, and we acted then as an encouragement one to another. So throughout the journey, we knew that we were to go through this because we could handle it. And how true that was. I mean, look where we are, what we're trying to do now. But the second one, the second person that said something is our outgoing SIOP Africa president, who also happened to be a lead pediatrician oncologist at the Uganda Cancer Institute, Dr. Joyce Bagala Kambugu. She kept telling us, because we had many questions all the time. She said something that has stood out for us to this day, a bold statement of, let us not borrow worry. Do not borrow worry. And that has been recurring in our journey. Do not borrow worry. Because we always had so many questions concerning her health, concerning her vital organs, concerning the reaction to the medicines. And she kept reassuring us and saying, do not borrow worry. And we have found ourselves repeating this same statement as we address parents. But it's profoundly her words, do not borrow worry. And just the way they handled our daughter at the treatment, allowing her, to be part of it, allowing her to, at her young age, even to address them. At some point, she told them, please do not call me by my name. Her name is Gabriela. She said, do not call me by my name. I am now a doctor and I've come to treat you. And my name is Dr. Lalala. So allowing us to enjoy the treatment journey with amazing words and amazing work, do not borrow worry has stood out for us. Thank you. Yeah.
Thank you so much, Kenneth. We do have another question from Dr. Sankin. Do you think the overprotection of the parents has any effect on the reintegration process? Do any of our survivors want to answer that first, or anybody have a burning desire to answer that? Or I can call on somebody too.
I can answer if.
Yeah, go ahead, Anna. Thank you.
I do not know if it's valid for everyone. So here I'm talking about personal experience, but definitely yes, because of the overprotection, I was socially isolated further in order not to get contaminated with, I don't know, having a cold when your immunity is low, or mixing with big crowds of kids, which are like, cage full of pigeons, full of diseases.
Yes.
So yes, definitely, because my parents were overprotective, they isolated me at a certain extent from a social perspective, which led to me reintegrating a lot slower. Yeah.
Okay.
Thank you.
Yeah, thank you. Thank you very much for answering that. Charlie, would you like to answer that question about if overprotection had any effect on your reintegration process?
Sí, claro. Yo en varias ocasiones he hablado con mis papás de esa situación, y ahora que tengo una hija de 6 meses, de verdad, no me imagino lo difícil. Escuchaba la historia de Kenneth, no me imagino lo difícil. Admiro bastante, digamos, a Kenneth, su historia es increíble. En mi caso, igual, muy personal, mis papás muy preocupados de que no me reintegrara, ¿verdad? Porque decían, es que tienes que cuidarte. El doctor dijo que de igual forma todavía, porque estaba el primer año de tratamiento, paré todas mis actividades, ¿verdad? Y yo estaba en el segundo año de la universidad, dejé la universidad, estuve en tratamiento full y mi doctor me dijo en el segundo año, la recomendación es no reanudes actividades porque todavía estás en tratamiento, tienes glóbulos blancos bajos, estás susceptible a enfermedades. Mis papás igual, pero yo ya no podía con mi vida. Yo ya no quería estar encerrado porque me sentía muy solo. Entonces, creo que ahí, tal vez de la experiencia de hijo, yo reté a mis papás y les dije, no puedo, yo quiero regresar a las actividades normales, quiero regresar porque necesito, digamos, regresar a la normalidad para sentirme, digamos, lo voy a decir así, vivo, ¿verdad? Porque aislado yo me sentía muy solo y como les decía, en mi situación muy personal y creo que en Guatemala no hay muchas comunidades, ¿verdad? En las que aún en medio del tratamiento uno pueda sentir apoyo o compartir historias, o sea, me sentía muy solo. Entonces, después de un año de tratamiento, yo quise regresar, regresé. En el segundo año de tratamiento a la universidad, en su momento fue una cosa que me dio mucha vergüenza porque todavía no había recuperado mi cabello y tenía parches, tenía un pedazo de pelo por acá, otro pedazo de pelo por acá, otro por acá, y me sentía con mucha vergüenza de regresar así porque yo me sentía feo, la verdad, pero el no quedarme solo era un sentimiento más fuerte. Entonces dije, no, en el segundo año quiero regresar. Y desde mi punto de vista como hijo, seguro eso le causó mucho caos a mis papás, porque contra la recomendación del doctor y de mis papás, el segundo año regresé a actividades normales.
Thank you so much, Charlie. Kenneth, we had a question come in for you. Currently, you as the parent organization that you're head of, and that you founded, do you have some power to affect the government or Ministry of Health? How do you think that SIOP, CCI, or the WHO can help? And you're currently on mute if you're talking, Kenneth.
I'm sorry about that. Yes, as I have a child cancer care, we first and foremost recognized by hospital, the leading center for treatment of children with cancer in Uganda, and in partnership with them. We are also a part of a wider community within the Uganda Cancer Society. And because of that, we are involved right now. Our government and our Ministry of Health is drafting a national cancer control plan because there was a need. The government realized to centralize cancer treatment. And of course, as parents and as stakeholders, there was an opportunity for us to have an input because the plan is going to have a direct effect on our children and on ourselves. And so currently, that is what we are doing. We are involved in drafting and studying together with the Ministry of Health in Uganda. And there have been several steps. Eventually, the National Cancer Control Plan will be brought before Parliament, and it will become, law, and therefore begin being implemented. So currently, if I understand your question, that is what we are trying to do now. Yeah.
Thank you so much. Manar, we do have a question for you. Are you able to answer?
I'm sorry, Manar had an emergency at work. She had to leave. Sorry, Mariah.
Gotcha. Okay, thank you for letting me know that. Let's see if we've got any other questions here. So this is a question.
Go ahead, Mariah. Go ahead. I just was
I
wondering,
just-
Chris, Dr. Chris, they were wondering a specific question for you. Is there a difference in the gender selection for treatment? Is there any discrimination between girls and boys who come for treatment of childhood cancer in DRC?
Yes, Julian. Hold on.
Yeah, did you see in the DRC, is there any discrimination that more often you see boys being treated or more often you see girls? Is there any discrimination in the gender?
No, you don't have the discrimination of the gender in DRC for the treatment. Yes.
Thanks a lot. Over to you, Mariah. Back to you.
Thank you. So we have one question left that we could get answered today. And I just wanted to say before we get your answers to that, thank you so much for sharing the survivors. You've done a wonderful job. And it can be difficult to talk about, but you've done a great job with everything. So we do have one last question. Do you think that with CCI and SIOP, sorry, I had the question up here and it just disappeared. Here we go. Do you think announcements or flyers by SIOP and CCI in the social media could help with sorry, that question is specifically for Manar. I think that was the extent of the questions for today that we could answer with the people that we have here. Unless anyone wanted to just give some closing remarks, we have about a minute left if anyone would like to. Otherwise, I would turn it back over to you, Julia.
That sounds great. There was one more question for the DR. I just wanted to check, Chris, there's something, let me look at Jeff. It was nearly near the beginning. Chris,
Yeah.
Dr. Chris,
Yes. Yes.
Jeff Moliba wants to know, what is a common international challenge to face for the cancer in Africa, knowing that the economic situation is unable to support laboratory and treatment properly? Do you have any way that any NGO or civil society that is helping the families to pay for treatment?
In DRC is now we have a program for cancer, but this program is beginning just for 6 months ago, and we found just GFAOP in 3 provinces. In Kinshasa, the capital, and Lubumbashi, and Bukavu. Bukavu is a province near to Rwanda. But this one we can fund. GFAOP gives some medicine for people who have a cancer. But we don't fund the NGO in DRC, especially for cancer. It's a big challenge for our country. It's a big country, but no NGO for support the people who have a cancer.
Okay, thanks so much, Dr. Chris. I think it would be great if you guys could talk to Kenneth and find out how they got started in Uganda, and maybe and also working with CCI, which supports parent groups, which could be really helpful for your parents as a new unit, you know? I think we're going to get you in the network now. I'm so grateful for everybody that has shared their story, their advice, their guidance. I thank everybody. We're going to have a closing comment from Mr. Rodney Wong, who is the president of CCI. Rodney, I think I see you here, but I think we have a recording. Would you prefer we show the recording? I don't know if he's live because I don't see his picture. Anelia, why don't you go ahead and show the recording? And we are actually we have recorded the whole session. So let me assure everyone that's joined us that you can see this session on the YouTube channels of both CCI and SIOP when we are finished. It will probably be up by the beginning of next week. And go ahead, Anelia, you can show Rodney's closing.
Dear friends, as we draw this survivor webinar to a close, I'm filled with profound sense of gratitude and hope. Over the past hours, we have heard incredible stories, exchanged knowledge that empowers, and foster connection that strengthen our global survivor community. To our survivors, your courage inspires us every day. You remind us that each moment is precious and that the human spirit is indomitable. Let us continue to build and strengthen our survivor network across the globe. To the families, caregivers, and healthcare professionals, your unwavering support is the backbone of this journey. Thank you, and thank you to our close partner, SIOP, for believing in CCI and your partnership in this journey. Thank you to all the speakers for sharing your incredible stories. As we part ways, let's carry forward the commitment to support childhood cancer research, advocacy, and awareness. Let's continue to be the voice for those who can't speak out and the strength for those who falter. Together, we are a beacon of hope. Together, we can make a difference. Thank you, and thank you for your dedication, your passion, and your belief in the future where childhood cancer is no longer a life sentence. Stay strong, stay connected, and let's look forward to a world free from childhood cancer. Thank you.
Fantastic. So thank you to everyone who attended. We are actually on time, which I think for many Zoom webinars is a miracle. I thank everyone for sharing your stories, the translators who did such a fantastic job, and we hope in the future we can get more languages, because I think we would like to have our messages go out and our experiences go out to everyone, that we can not let language be a barrier. And we appreciate you taking your time out on a Saturday to join us. And good evening if you're at night, and good morning for those in my time zone in California. And for those in the midday, we appreciate your attendance and are grateful that we are now a community and a network joined and hope to get bigger.
Thank you.
Thank you. Thank you.
Thank you. Great
It was
session.
great.
Thank you very much.
Thank you all.
Privilege for me to be here.
Nelia, can you let us know when you've closed us out and we're alone in the panel room?
Sorry, Julia, do you want to stay a bit more?
No. Can you tell us when you have closed out our broadcast so that we are left alone in the panel room?
Yes, people are still stepping down.
Okay.